Hi everyone, this is Michael Fensky. This is my first CJM video for Nurse 6976. I'm going to pull up my CJM here and I'll kind of give you an overview of the patient I had this week. So this patient's initials were JO. She's a 66-year-old female, admitted on 2/17, um, presenting with presenting for evaluation of abdominal pain. She was a full code, allergic to penicillins, and had consults for vascular medicine and infectious disease. She arrived via EMS from a rehab facility, which I'll get to shortly here, why that was the case. And her admitting diagnosis was an abdominal wall hematoma. Her HPI, according to the emergency physician note, patient reports experiencing severe abdominal pain in her abdominal wall, described as more intense than previous recent back pain. Patient was getting subcutaneous Lovenox as a bridge to Coumadin therapy. And in regards to why she was at the rehab facility, she was recently admitted from February 8th to February 14th for osteomyelitis of the L4, L5 vertebrae, and was discharged to that sub-Q rehab for IV antibiotics. She denied nausea, vomiting, diarrhea, changes in urinary function, and expressed need for additional pain relief. Medical history includes pulmonary embolism, osteomyelitis of the L4, L5 vertebrae, GI bleeding, hyperlipidemia, and splenic laceration. She smokes a quarter pack a day of cigarettes and denied alcohol or illicit drugs. Here you can see her vitals. On the left here are the most recent ones that were taken the morning that I was at the clinical, and these are from the previous night. As you can see, her blood pressure was a little bit lower, SpO2 was a little bit lower, and heart rate was a little bit lower. Temperature was slightly improved. Normal sinus rhythm on tele, regular diet. She had a single lumen pick for IV access. So up one with a walker, no diabetes, on room air. Fall precautions and bed alarm in place for the safety. Here you can see her labs. Um, Generally pretty unremarkable, but the most notable thing that is pertinent to her in this situation is her red blood cells and hematocrit. And since her diagnosis was the abdominal wall hematoma, the fact that these had decreased just a little bit from the emergency department compared to a couple hours before I got there started to lead the clinicians to believe that she was losing blood to this hematoma, and it was kind of exiting her vascular space, um, which kind of may have something to do with the decreased blood pressure that you see here. Um, in the ED, they did do a CT of the abdomen pelvis that showed the abdominal wall hematoma and the degenerative changes to the L4, L5 um, regarding the osteomyelitis that she was still being treated for. Here you can see her medications. She also had a history of ADHD, so she was getting amphetamine, torvastatin for the hyperlipidemia, pregabalin or Lyrica for the nerve pain, vancomycin to treat the osteomyelitis, and loperamide because the the vancomycin was giving her some diarrhea. On exam, um, not a whole lot going on here. ANO times 4. HEENT was all within defined limits. Lung C-tab, regular rate and rhythm, good pulses radially and pedal. Um, Regarding GI, I didn't really see explicit evidence on exam that this abdominal wall hematoma was um, super present. Obviously, the CT saw otherwise, but I didn't see a whole lot. Normal active bowel sounds. Last PM was the morning that I assumed her care. She just had a Purewick in place, dry and flaking skin throughout, generalized weakness, secondary to pain. Answered questions appropriately. No cultural, spiritual, or social justice observations. In regards to the pathophysiology, um, in relation to this patient's past medical history, her previous PE may have contributed to the hematoma formation. More likely, however, is the trauma from the osteomyelitis that is somewhat nearby in the abdominal cavity. Hematoma is a collection of blood that forms outside of a blood vessel where there is space to accommodate blood accumulation. In this case, it's likely the rectus abdominis muscle. I got that from a source here. The patient's anticoagulation use and female gender could have also played a role in the formation of the hematoma. And overall, the anticoagulation use and recent trauma in the area likely caused this hematoma. This is much of the same that I went through in the pathophysiology, history of PE, on anticoagulation. Vital signs here, not the biggest priority, but the slight drop in blood pressure could have something to do with intravascular blood loss. And then the red blood cells here, it's kind of the main, most important uh, topic regarding how this care goes from here. Not a huge drop, um, but in addition to the lower blood pressure, the doctor could kind of was leaning towards believing that um, she was losing blood to this hematoma. The CT abdomen, pelvis confirmed the hematoma, and not a lot of pertinent assessment findings. For the pharmacotherapies, I wrote that the vancomycin is the most pertinent medication, as she's still on that to treat her osteomyelitis. For the three most important findings, I wrote that the red blood cells slash hematocrit is a concern for bleeding. The imaging showed the abdominal wall hematoma, and the order to infuse vancomycin continues to treat her osteomyelitis. A lot of the same here for pertinent provider orders. Infuse vancomycin to treat osteomyelitis. Patient has her infection treated adequately. Hold anticoagulation to decrease the bleeding risk, and order repeat imaging for the hematoma, which did not happen when I was there, but that was kind of the plan going forward. In terms of complications, the patient is at a greatest risk to develop. I wrote acute blood loss anemia as evidenced by the decreasing red blood cells, um, worsening infection slash hospital acquired infection, evidenced by the osteomyelitis in her hospital stay. And then I wrote muscle atrophy just by the decreased activity and increased pain that she was experiencing. I wrote the deep red blood cell count should be observed the most closely. Five appropriate nursing interventions, monitor vital signs, monitor for hypovolemia, assess the abdomen, identify changes in the hematoma condition, even though I didn't really see a whole lot when I did mine in the morning. Hold anticoagulation to decrease the chance of bleeding, pain management to provide a sense of healing in the presence of severe back pain from the osteomyelitis. And then prepare for possible surgical intervention if it's indicated. Um, CNA can help with vitals, hygiene needs, positioning. Therapy can collaborate to ensure the patient maintains physical and functional ability. APPs and doctors can help establish the best plan of care. And in regards to what needs to be done immediately, there wasn't really anything. Although the patient was in stable condition, although does certainly need to be continuously monitored for worsening condition. This is much of the same that I wrote right up here. Throughout the day, I did actually get to be in the room when the hospitals came around, and what he did say was expressing that the the red blood cells needed to be watched, and that they would be doing repeat imaging to check on that hematoma. Interacted with the CNA to ensure the patient's needs were adequately met. For patient family education, I actually found out that the patient was a nurse for over 20 years and was pretty well educated on healthcare. However, smoking cessation would obviously be something to address in discharge teaching. Safety considerations, patient was encouraged to call to get up if she needed help due to her increased weakness and pain. And again, the vancomycin was the most pertinent medication that the patient was receiving for osteomyelitis. So that's all. Thank you for listening and take care.